Welcome to another episode of the Wealthy Podcast. Today, we are speaking with Dr. Nevin De Korompay, who is an interventional radiologist here at KGH. Dr. De Korompay was instrumental in our fundraising effort to bring EVT, a very cool procedure that allows stroke patients to come in and sometimes walk out of the OR. Dr. De Korompay is extremely passionate about what he does. His energy is amazing. He shares amazing stories about healthcare, and I really hope you enjoy this episode. So today on the Wealthy Podcast, we are welcoming Dr. Nevin De Korompay. How about I try that again?
No, you should just run with that.
Okay. Dr. Nevin De Korompay. Do you want me to start over? Should I?
No.
Okay, well, now I have to because I stopped. Yeah. Okay. Today on the Wealthy Podcast, we are welcoming Dr. Nevin De Korompay. Dr. De Korompay is an interventional radiologist at Kelowna General Hospital. He has been pivotal in establishing advanced therapies in vascular surgery, neurosurgery, and minimally invasive surgery for lung cancer, as well as advancing therapies for liver cancer. Wow. We're going to unpack that a little bit. With support from the KGH Foundation donors, Dr. De Korompay has also developed an interventional oncology program at Kelowna General Hospital. I first met Dr. De Korompay in early 2020, I think it was. He might not remember this, but I do. It was the day before the world shut down for the pandemic. Do you remember we had a photo shoot? Yes, in the Centennial lobby.
Yes.
Because we were preparing for our stroke campaign. To in part bring EVT, which we're also going to unpack, to KGH. And literally, like, as we finished that photo shoot, like, all of the communication was coming in that the world was shutting down. And we were like, okay.
To rearrange some meetings.
Yeah, totally. And we actually had to rearrange that campaign, and we didn't end up launching for a year. But when we did, you were a huge asset to our fundraising effort and just such a joy to work with. Dr. De Korompay is very passionate about his work, and our donors absolutely adore him, as do we.
Oh, thank you.
Last year, Dr. De Korompay oversaw the implementation of the $9.6 million interventional radiology suite at KGH. And this is like the longest bio yet because it's so awesome.
I should have added more. I should have thrown more stuff in there for you to chew on.
And he was recently named one of the Kelowna Chamber of Commerce's top 40 under 40. So like he's done all of this and he's not even 40.
Well, I'm 40 now. Like, that's the thing. I snuck under the barrier because people were like, wait, you need your 40th birthday? And I was like, no, it's like at the application.
Okay, so, well, yeah. Fine. But
so now I'm 40.
Well, you don't have to tell people that.
Yeah,
you can still be like, oh yeah, that's me, top 40 under 40. Dr. De Korompay is a family man. He's a father and a friend to many, and I'm so looking forward to this conversation. Welcome to the podcast, Nevin.
Thank you for having me. This is so impressive. Like, you guys have such a great setup. And,
yeah,
I'm stoked to be here.
Yeah, and I'm really stoked to have you. So before we sort of get into all of the cool stuff that you are involved with at our hospital, I kind of wanted to like rewind a little bit and ask you, how is it that like this is a podcast about health, and we've called it Wealthy because we really feel like health is wealth. It's like the vital component to living a fulfilled life. And you work in healthcare every single day. So looking back, what was sort of the first time that you really became aware of how important health is, or like where healthcare or a health situation impacted your life?
Well, so for me growing up, I mean, like, yeah, I'm in the hospital every day now, but so my dad was an orthopedic surgeon when I grew up, right? So that obviously set a big tone in my life because, some of my earliest memories are like my dad rounding on patients and him dropping us off at the nursing station for modified daycare. And like, you know, we'd go in with when he'd round on patients, there'd be like weird hip arthroplasty models in his office. There'd be videos that he'd be watching of arthroscopy and be going on the TV. He was the orthopedic surgeon for the Rough Riders when we were in Saskatchewan, and later for the Blue Bombers. So I'd be around the sports teams and the injuries. And like, I always remember one of the things that kind of struck me when I was a kid is, you know, you'd be walking around, you'd be, you know, out with your dad or whatever. And then someone would be like, oh, like, is that, you know, is your Dr. De Korompay, is it your dad? Oh, he fixed my hip or he scoped my knee. And it was surprising the number of times that would happen where people would just randomly come up to him and say, hey, I don't know if you remember me, but like you did the surgery and my knee is way better. And so sort of, you know, throughout my childhood and throughout my youth, like, you know, medical care, hospitals, and especially, you know, physical health in relation to joints because of my dad, that was always very much sort of, you know, part of my reality. And so I was very acutely aware of sort of, you know, the role doctors play and the role health plays in your life because sort of, you know, I was living it as a surrogate through my dad that whole time.
So you didn't actually have like an aha moment, like, oh, it was just kind of like ever present.
It was always there. And, you know, I think, you know, we all kind of, you know, a lot of us idolize our parents and, you know, kind of idolize my dad. And so all the way through my life, like it was always just around. Medicine was always around, and I think it was always on my radar, you know, throughout my youth, high school, university, that kind of thing. So I think, you know, it was always kind of there. Yeah.
So did you think that, like, was there ever any doubt for you? Like, did you say, I might be a doctor, or maybe I'll be like a marketing director?
So yeah, I had that exact moment.
Really?
So I remember I was applying universities, and I remember I got into like Queen's Science and Queen's Business. And I remember I went through this like really moral dilemma, and I was like, because I felt like I was at like that two roads diverge in a Yellowwood moment. And I was like, oh, if I go here, am I going to be the health guy or the, you know, banking guy? And like, it was very stressful. And I remember I talked to like my dad's business partner or a friend of his in business, and kind of, it was stressful for me because, you know, I was like a stressed out kid and was always worried about like, you know, achieving and putting pressure on myself. But I found that hard. But ultimately, I just kind of, you know, went with your gut and, you know, ended up going down the sort of science route. And that's kind of part of the journey that led me here.
Well, it's interesting because, not that I want to, you know, suggest that all surgeons are sort of antisocial and not really into, you know, kind of like the people side of things, because we know that's not true. But you are very extremely kind of like the other way. You're very much a people person. So was that something that like you wanted to kind of maintain, or you just can't help it? Like,
I think, I mean, I acknowledge the, you know, the cliche of the grizzled old, terrible with people surgeon. You know, I've always enjoyed people and, you know, team sports and interacting, and you know this may be getting ahead of things, but I remember when I was picking radiology, people were like, why would you go into radiology? Like, you want to just hang out with a computer all day? And so I enjoy interacting with people. I feel that has been, you know, a part of my personality or my makeup that I think is advantageous in healthcare. But certainly, I think, you know, every healthcare job is so hyper local, and you know, there's all these cliches floating around about various jobs. But I mean, at the end of the day, we all bring different skill sets to the table, and I think that just, you know, I'm fortunate that I found a spot that I can use that skill set, and it can hopefully, you know, resonate with my patients.
And I definitely think it does. So I kind of my second question, like official question, what exactly do you do? So you're an interventional radiologist.
Yeah. So I mean, my mom, I still don't think my mom even knows exactly what I do. And this is a common narrative. Like, if you listen to IR podcasts, like, you know, I was listening to an episode the other day, and they're like, yeah, how do you tell people what you do? Like, what's your canned response? Because like nobody's really figured out a good one. So in short, I would say, you know, most people are aware of, you know, CT scans, X-rays, ultrasounds, MRIs. Most people have heard of that. So I read those, but then like my bonus feature is that I can use those technologies, those scans, to do minimally invasive kind of procedures or surgeries. And so sort of the story of IR and interventional radiology is that, you know, they've been doing X-rays for like hundreds of years, or almost 100 years. And then there's a guy in Oregon in the 60s who, before CT scans and things like that, if you want to take a look at somebody's blood vessels, you have to like put a needle in their artery and just like shoot X-ray dye in there and then take an X-ray. And that's how you would do it. And, there were no MRs, there was no CT scanners. So we would be doing lots of these. That was like part of the radiology
So like
job.
the dye would like light up the vessels?
So you literally like you put a needle in the tube in your leg, for instance, and then you shoot a bunch of dye, and the dye shows up on X-ray, and you take an X-ray, and then you see a picture of these blood vessels in the legs or the heart or the brain. Like that's how they would diagnose brain tumors, is they would take a look at the blood vessels and they'd say that little artery is moved over 2 millimeters, so I think you have a brain cancer. Like it was wild, right? It's very, very low tech in retrospect, but that's what they did. And then in the 60s, there was a guy, so they're doing all these like, they're called angiograms, right? Pictures of these blood vessels. And then there's a guy that was like taking these pictures. And then there was this very famous story, this lady named Laura Shaw in Oregon, and she had a narrowing in the blood vessel, right? I think we've all heard of, narrowings in blood vessels. And she was having an infection in her leg, and the doctors were like, this infection's out of control. We got to chop off your leg. And she said, like, over my dead body. And they're like, yeah, that's the point. Like, if we don't cut this thing off, you're going to probably die from this infection. And then she refused. And so this guy was taking a picture. He says, hey, I got an idea. I think instead of me just taking the picture, I can like put a little wire down there and like, like Russian dolls, like the things that kind of stack on top of each other, bigger and bigger. I can put on a tube and then a bigger tube and then a bigger tube, and I can maybe open this thing up. And they did it, and it worked. And without any surgery, without going to sleep, they managed to open up this blood vessel. And she like walked out of the hospital like a week or two later instead of getting her leg cut off. And so this was like the aha moment. And
so they just randomly did that? Like,
yeah, it was a different time. Like you just did things back in the day, right?
Yeah.
Like it was a bit more of a Wild West.
Yeah.
But this was the moment. And then so from that guy, like he met a guy in Europe named Grunsig, who was the first guy that's like, hey, maybe I can put a balloon on that tube and we can balloon things open. And then, I met another guy who said, oh, we can do a stent to keep things open. And then other guys are saying, oh, we can do coils, and then we can do, aneurysms in the brain. And then, a few years later, another guy says, oh, we can like put heart valves on these tubes and then do these minimally invasive heart valves. So this whole like minimally invasive world kind of exploded from that moment. And so that's sort of the raison d'etre that we have. We just basically can do these procedures where we can get places with tubes and wires and needles. And then when we get there, we can do things in a minimally invasive fashion. So
like before the tubes and wires and little tiny baby cameras and like all of that stuff.
Yeah.
And you talk a lot about minimally invasive. I feel like that's kind of your jam, right? What would you do before? Like you would have to like cut them open?
Yeah, you would have like the traditional surgeries or the traditional for instance, if you needed a biopsy, right? Before ultrasound guided biopsies, and so right now it's like an hour procedure, right? Like you can do have a coffee and then do that and then go shopping later, right? But before you'd have to go in and someone would like either freeze you or put you under and then take a scalpel and go in and find the thing. And so there was and then that's what you'd have to do for everything, right? Surgeries in your legs or biopsies. So everything we do now is. And sometimes you still need the big surgeries, right?
Sure.
But sometimes there's now options where you don't, and you can get things done in a minimally invasive fashion, which some people prefer.
So, and I know that sort of like, this isn't sort of your area specifically of expertise, but I'm curious, like you talked about angiograms and stents and all of that, and that literally has changed the prognosis for so many cardiac patients, right? Like, so patients that may have died from heart attack are now able to kind of not and continue to.
Yeah. And that same story is kind of, that same story exists everywhere in the body, right? Because, that happened in the heart, it happened in the leg, and every time it's sort of that natural progression of medicine, right? So the first time they did this in the leg, there were some people that said, hey, this is great. And there's some guys that are like, you guys are crazy.
Yeah.
How dare you experiment, or like, what do you think you're doing? This is a terrible idea. People's legs are going to fall off. And so, that's the sort of natural course. It happened in the legs, happened in the heart, happened in the brain. And then, so it really, there's certainly something that's kind of cool and sexy and novel with these new procedures and minimally invasive stuff. But then you also have to kind of prove that it works, and you have to kind of put that up against the established practices and the gold standards and see, which one wins. And that's kind of, the medical system in a nutshell, right? So it's one thing to just have this new fancy cool idea, but then you have to prove it works.
Yeah.
And so in my lifetime, before I became, when I'm in my training, it was still kind of that Wild West world where you'd be like, hey, let's try this. Hey, this patient's in trouble. Why don't we try this? And then now it's sort of more of that, truly scientific randomized control studies prove it works. And, we'll get into things like EVT and stuff later. But yeah, that was sort of the challenge. And this is sort of that epoch or the era right now where you see things were one way before and then they're one way after. And then you kind of have to like build these systems and get resources to kind of employ the new science to help people.
Mm-hmm. It's so fascinating. And thank you for sort of unpacking that a little bit. We had one of your colleagues, Dr. Brenda Farnquist, on a couple of weeks ago, and she was talking about, we were talking about how radiology is sort of like the unsung hero of healthcare because people don't really realize how imaging and all of these advanced technologies are really impacting like not just, the big things like whether you live or don't, but also just like how long you're in hospital or how long it takes you to recover. So what are some of the benefits, like just in general, for minimally invasive procedures? And we'll get, like you said, we'll get into EVT, but like just in general, why is this a good thing?
So in general, if you present with a health problem, right? Obviously you want to solve that problem. Right. And so, for instance, I'll give you an example. Is like, let's say you have a blockage in your carotid artery. OK, most people know that carotid artery, it's the blood vessel in your neck. It supplies the brain. So if you have a blockage, firstly, imaging is going to diagnose that. Right. It might be an ultrasound. It might be a CT. It might be an MR. I guess in the old days, somebody would present with symptoms and then they get imaged. But now we have other ways where you can kind of detect things earlier before they become bigger problems. But once you know you have a problem, you would say, OK, what are my options here? And sometimes there's like only one option or only one good option, or sometimes there's no good options. But for most sort of health problems that somebody has, you'll have like, there's A, B, C, or D, or plan A, plan B, plan C. So with the carotid artery, you can do surgery. You can go under and have somebody clamp it and then core it out, which is called an endarterectomy. You can do medical management, just take medications. Hopefully that fixes it. You can do an interventional radiology procedure called a stent, carotid stent. Which is kind of minimally invasive. And then there's something else called like a TCAR, which is a hybrid. So there's all these options. But then, if someone, it's like when you're buying a car and someone says, here's a BMW, here's a Mercedes, here's a Jaguar, here's an Audi, which one do you want? Which is the best? Like that's what people say. Oh, well, which is the best, right? Yeah. And sometimes, well, what's the best? Is it, what do you care about? Like, which is the feature that matters to you? So for some people, they'll say, well, it doesn't really matter how you get it done. I just want to know that this problem is going to be fixed and it's going to be fixed to the maximum percentage point and it's never going to come back. And I don't care, if I have to stay in the hospital for a week, or I don't care if I have to have a higher risk procedure. I just want to know that when I leave, if everything goes well, that it's done and dusted. Whereas other people will say, well, like, I don't want to be in a hospital for several days, or I really don't want to have, the risk of, a nerve injury in my face. So maybe they would opt for a more minimally invasive procedure with a slightly higher risk of, recurrence down the road. So you're kind of comparing apples to oranges to kiwis. But coming back to your original point. So a lot of people do prefer minimally invasive, right? And life is trade-offs. So the minimally invasive procedures, and there's for a lot of things, there's minimally invasive options, but it's like, what's that trade-off? So how much, how much am I losing in efficacy, but gaining potentially in, not being off work or not being stuck in the hospital or, dealing with things like that.
And getting back to my life.
Exactly. So whenever, and that's why it's important that we have sort of conversations with other and teams with other physicians and multidisciplinary rounds where we can look at these patients and say, okay, for this patient, here's 4 or 5 options. What do we think of, when you're a hammer, everything's a nail, right? So you think yours is the best. So I'm an interventional radiologist. If you ask me like what's important, like I'm gonna say, oh yeah, minimally invasive is important. But if you talk to my vascular surgery colleagues, they might be like, well, what's important is that we have all the options available and you can have surgery. So there is a little bit of a bias.
Yeah.
And at the end of the day, we all just want our patients to do well.
Yeah.
But if you ask me, and you ask the interventional radiologist, they're going to say, well, I think minimally invasive is very important to people. And I think this is something you should strongly consider due to its minimally invasive nature.
It's a strong sell
Yeah.
coming from you for sure. So you do, as an interventional radiologist, just to be very sort of clear, the cases that you have are quite complicated. So I would say anyway, I mean, I think I'm in awe of physicians in general because I studied communications and English in university. So anything in the sciences is just like mind blowing to me. But I've heard, you've shared stories about remarkable saves, blood clots in the brain and aneurysms. And I mean, we're not talking about the leg, and not to diminish the leg. We need them.
Leg is important.
The leg is important, but so is the brain.
Yeah. You ask a neurosurgeon what's the most important organ, they'll probably tell you it's the brain.
Yeah. I know.
But then the cardiac surgeons will say, blood needs to get to the brain, so the heart is the most important, and so on and so forth.
I know. Yeah. And I don't want to play favorites with parts of the body because I love all of mine equally. But I would say, brain surgery just sounds really complicated and with potentially bigger consequences attached to it. So like, to really help illustrate what it is that you do, can you kind of share a little bit about who your patients are? I know there's a sort of gamut, but like...
Totally. So like, it's tough because most specialties are defined by like an organ system. So like, you say brain surgeon, oh yeah, I do stuff in the brain. I say, cardiac surgeon or cardiologist, they say, oh, you do the heart. We're kind of a weird group because we have all these sort of orphan procedures of all over the body. So, and that's kind of what makes my job fun, right? Because we can have a patient who comes in with a stroke, who's, maybe an elderly patient, who's got, blood pressure and other risk factors that causes that older people are more likely to get strokes, but we have had strokes in really young patients too. We can have cancer patients. I mean, at the end of the day, my job is, can I get somewhere minimally invasive and fix something? So that can encompass a lot, right? So we can have a guy who's got, a big prostate, and we can go down on the prostate and shrink that. So it can be like a healthy guy, prime of his life, just with some prostate problems. So that can be a patient. The next patient could be a cancer patient who's got like a liver tumor. And then, so we're coming in and trying to get a little needle into the liver tumor, burning it, getting, curing the cancer. And then, then we can have a woman who's having fertility problems and has got a blocked fallopian tube. And we'll actually go into the fallopian tubes and unplug them so that they can, have a higher chance of having. So it's just really total random hodgepodge of patients. But we see, and sometimes there's kids that need things like feeding tubes or vascular access. So we see babies, we see 100-year-olds, we see healthy people, we see really unhealthy people. We see kind of everybody.
Wow. I didn't realize that. Maybe because and let's talk a little bit about EVT. Yeah. But our relationship began around a very special piece of equipment. What do you call it? You call it equipment? Endovascular thrombectomy.
Yeah, procedure. And it's a procedure that requires a lot of expensive equipment.
Yes. And so backstory is the KGH Foundation's campaign funded or helped to fund the equipment and the suite that contains the equipment, which is extremely impressive. It's just amazing. So can you kind of unpack excuse me, what EVT is?
Yeah, for sure. So we kind of talked about, some of the IR and the procedures, and sort of, my job is to get somewhere with equipment in a very minimally invasive fashion. And so one of the places we can get to is the brain. And what can happen to some people when they have a stroke, I mean, most people have heard of the idea of a stroke, is that sometimes you can get these blood clots in your body that form for whatever reason, whether it's like atrial fibrillation or, atherosclerosis, but you get this clot that forms in your body and it gets shot up to your head. And like a beaver damming up a river, it blocks blood flow. And that's when you start experiencing these symptoms of stroke. And obviously, some parts of the body are better at handling lack of blood flow than others. The brain sucks at handling poor blood flow. Like, it starts dying right away.
Good to know.
Yeah. So, but that's why there's these campaigns, like, fast and to pick it up, because time matters. Every second kind of counts, which was obviously
every moment matters was our campaign.
Yeah. So, just to dovetail under the promos there.
Thanks.
You're welcome. So anyways, so you've got this clot, it's blocking the blood flow. So the idea with EVT, endovascular thrombectomy, is what it stands for. Endo meaning in, vascular meaning blood vessel, thrombectomy meaning removing the thrombus, thrombectomy. So that's the kind of Latin breakdown for you.
What's a thrombus?
Thrombus is like the clot. It's a fancy doctor word for clot.
Okay,
yeah.
Okay.
So basically, these people are there, and one of the ways to fix it is to literally just go up into the brain and find where the clot is and yank it out and restore the blood flow. And so that's in a nutshell what the procedure is. Obviously it's fancy and it looks cool when you see the real thing, but basically you got a giant goober blocking the blood vessel in your brain. We go get it.
Yeah, you've totally so eloquently summed up that procedure,
Yes.
but I know it's very delicate. So what happens? Somebody's coming in, they've had a stroke or they're experiencing a stroke. And so they come in, they've made this, their family has made the decision, let's have this procedure, the EVT. Maybe they're experiencing some of the symptoms of stroke. Maybe can you share kind of like what I know you have them, like a successful EVT, like patient comes in as this, patient leaves as that.
Yeah. So, I mean, it's always very varied, but like some of the, the really great stories are someone will come in, they're normal, they're at home, they're eating soup, and then suddenly, half their face is paralyzed, they can't move their arm. The family says, oh, something's going on here. They call the ambulance brings them in. That's kind of step one. They get assessed and some emerge. Maybe it's here, maybe it's somewhere else. Some doctor says, oh, we think you're having a stroke. You do a scan. There's the radiology component coming in saying, oh, yeah, there's a stroke. And here's the reason why. Because sometimes it's blood clots, sometimes it's tumors, sometimes it's other things. But you confirm it's that. Okay, so then they activate the stroke team. They get seen by the neurologist. The neurologist confirms sort of the findings. They talk to us. We review the imaging. And we say, okay, this patient's got a clot. It's in a good spot. We think we can help them. They get transferred to our suite, our fancy suite.
In a good spot.
Yeah.
A bad spot.
Well, they're not all great spots, but
right,
certainly,
accessible.
there's you look at the pipes and you say, okay, I think I can get up those pipes. Or some people are like, ooh, that's going to be challenging.
Yeah.
And then they come into our angio suite. We got our whole team of techs and nurses and anesthesia. And we basically will go into the blood vessel. We take a little needle, make a little pinhole into either the wrist or the leg. And then using a live x-ray, and I think you've seen these videos before, I've shared them with you. We just drive these tubes up and, you go, okay, well, you're at the leg. Okay, let's go north to the aorta. Okay, let's go up the carotid. And then you go to the brain. You say, yeah, there's the blockage. And then you just using sort of little tubes and wires, bigger tube up, get to the spot. And then sometimes we'll just put a little kind of vacuum cleaner suction on there to trap it out. Sometimes we'll have to use a stent to kind of trap it. And then you basically pull it out and take a picture and then you go, yeah, it's open.
Yeah.
Just that easy.
I know.
And so to your question about, what's a good success story. So you have patients, they come in, they enter the room, they're kind of paralyzed on one side of their body. And then we've had a few patients where you do the procedure, you pull out the clot, blood flow is restored. And they're, it's like Lazarus. They're up, they're moving. I've got I remember there's one vivid memory where, the patient came in paralyzed. And then after I'm looking in the room, we're kind of talking about the case and doing our notes and writing orders. And I look in the room and I can see both their feet wiggling on the end of the bed where they couldn't move one before. So, it's that instant kind of, and they're not all like that, right? That's a big win. But it's certainly a gratifying feeling where someone is that disabled and then they walk and, they're kind of back to normal.
I know. I think you're like, I am astounded by the success potential with these procedures. I know you get very excited about it. We talked to Dr. De Korompay just about how debilitating stroke is for patients to survive a stroke, right? So this technology, this procedure is truly like magical.
Yeah.
I think that's fair to say.
Yeah. I mean, I don't want to throw in too much hyperbole, but
I know.
I mean,
that's what I do.
And this has been in my sort of career lifetime, which isn't that long, but when I was a trainee, it was still experimental.
Yeah.
Right. And then 2016 was the year where all the studies started going ding, saying, oh yeah, this is big. And like, you need to be doing this. And that's why we've experienced so much radical transformation and needed all the support from the foundation to sort of be like, okay, well, this is the new standard because this makes such a massive difference for people. We have to do this. Like, this has to happen, because to not do it, knowing how much of an effect this has and knowing how much this helps people, like, it's sort of, indefensible not to set this up and do this for people. Right. Yeah.
I, just to like defend my hyperbole, I remember reading, an article in the New York Times. I think it was probably around maybe 2018 that it was published. Okay. I don't know if you remember it, but it was a big deal because it was basically talking all about EVT and how this was literally a game changer for stroke patients. So it's so cool that we have it here. And I know that you and your colleagues were a big part of advocating to bring that here so that interior patients in BC would have access to EVT. Because before that, like, where would they have to go?
Yeah. So when in 2016, when this became the new standard of care and everyone was kind of, so in 2015, like when I was working in Vancouver in 2015, if you had a stroke in Vancouver in 2015, because it was still kind of experimental, like you would pick up a phone and be like, hey, this person's having a stroke. Is VGH, is there someone available? No? Okay, try Royal Columbian. Is someone available? No?
Yeah.
Like, okay, good luck. Right? That was just because that was the landscape at that time when it was still experimental. And then 2016, so this is gold standard. So at that point, a lot of the resources, a lot of the heavy lifting was done by the Lower Mainland because they were the ones that had this structure available. So for most of the patients, like patients here, it was Vancouver, right? That was the only option. And people in sort of the east part of our region, they could go to Calgary. And Calgary, has to get a lot of credit because Calgary was part of like the OG developments. There's a New York Times article, if we're talking about New York Times articles, but about Calgary where they shadow people. And like Calgary was kind of one of the meccas of stroke therapy and EVT.
Oh, okay.
And they did some of the early work in publishing. So there's a lot of credit for the Calgary site for really supercharging stroke. But anyway, so a patient in Kelowna gets a stroke, you have to go to Vancouver. That's the only option. And hopefully the roads are open. Hopefully it's summer. Maybe there's a helicopter. Maybe you can't fly in the winter. So I think
that's a problem when every moment matters.
It's a massive geographical, like physical, social, all those. It's a big distance in many ways. So I think in that early time frame when things were in motion, I think the earliest someone ever got to Vancouver was like 6 hours essentially. And at that time, in stroke therapy, 6 hours was the cutoff.
Right.
After 6 hours, based on the data at that time, you wouldn't really take people for EVT at that point. You say, well, the data shows that we're not sure if this is going to help, so we're going to back off. So we basically never got I think there was one patient that ended up coming from Kelowna to Vancouver that even got the procedure.
Right. Yeah.
So it was just it was just not an acceptable.
Wasn't one of the options.
Yeah.
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 So this is like, I just want to make sure that our listeners are, really clear about how revolutionary having this technology in the interior is for patients that experience stroke. It's not an option for everybody, as you've indicated, but for those that it is an option for, it's just a game changer.
Totally.
So I just want to say, thank you for, being such a champion for that and for really helping us, rally the community. Community needs to be thanked as well because we raised $8 million to support that acquisition. But hugely beneficial for our region, not just the Central Okanagan community. So yay.
Yeah, we think so. And because we get patients from all over, right? And if you think it was 6 hours from Kelowna to Vancouver, think of people coming from Kamloops or Penticton or Osoyoos, or we get patients from all over. And so I think it is very it's important. And honestly, the list, the number of people to thank that were part of the team that brought it there, from the neurologists, the techs, the fundraisers, the nurses, everybody, because you kind of had to build it from scratch, right? So it was a very daunting challenge, and it was very stressful for a lot of people because we really wanted to do it right. We didn't want to kind of have a failure to launch or not execute it at the highest level. So it was a very interesting time for us, and of course it was during the pandemic.
Yes,
and so lots of challenges and lots of hurdles to overcome. But it's amazing to see where things have gone. Like from the early days of just the first few ones, and now we're doing like 100 a year.
It's amazing. Yeah, and just to kind of put it into context, how supportive the community was of this initiative. We had to delay the launch of the campaign, the fundraising campaign to support the acquisition of EVT here because of the pandemic. And then we launched it. So we launched it a year later. So we were kind of late. All of this was already in motion. So we had to hustle up to get the funding in place. But I think it was like we launched it in March and we were finished by like the fall. So it was received with so much enthusiasm in this community. And I just, that was one of the campaigns that really stands out for me, how we worked together. Like you said, it was a team effort. We really worked with you and your colleagues and the community to make it happen. And now it's here. So it's really very exciting. Also very exciting for you. I should share this, that during this campaign, Nevin would take great delight in sending us photos, as he mentioned. When the blood clot comes out, a picture is taken. I'm really not sure what for. Like, is it just for your?
It's like it's gonna like it sounds. Somebody sounds weird. Like when you put it in this vacuum of a podcast, like I sound like total weirdo. But it's almost like a trophy, right? Like you're kind of like, this thing tried to kill you.
Yes.
And then you show the patient like, this little thing right here was trying to kill you, and now it's like out. Right. Yeah. And like, some are tiny, some are massive.
Yeah.
And it's just, it's, you get that kind of instant gratification of like, this was there, this was like messing this person up, and now we got it out, and like, look at that. Like, isn't that wild?
No, listen, I totally get it. Like, what's the feeling of,
it's
like
just,
getting,
you have these moments where like you're there, and we all will co-scrub. There's multiple doctors in the room. We get the little vacuum sucker to the clot. You put it up, and you start to pull it out, and then you're like, "Oh, is something coming out? Is something coming out?"
Is it like like, are you tender? You're like, "Oh, we don't want to go too fast."
Yeah, you're gentle with it, but but then like there's this moment sometimes where you're pulling it out, and then like it's like. So it's like corked. We actually use the word corked because the clot's like in this sucker, and sometimes it's really big and it's like trying to ingest it, and like and so you've got this like little tubing, and then you can see the tubing's like trying to like get this clot out, and you're kind of pulling it out, and sometimes you'll just see this like, and then like the clot flies out, and then someone's like oh, and then that moment when like, because you have to take a picture, right? It's live X-ray and X-ray dye that we talked about before. So there's this moment where you've got like the clot, you think the clot's out, and you're taking this picture, and it's almost like you're opening the envelope to see if you got in university, or did you get the job. You're like, did we get it? And then you take this picture, and then you see this like whoosh, and the blood flows through the brain. Everyone goes, yeah. It's a fun little kind of experience that. I mean, it doesn't always work. Sometimes you go, dopamine hit. It didn't work. Hey, we gotta go back again. Dang.
Does that happen?
Oh yeah. Sometimes it takes multiple pulls, or sometimes you don't get it out at all.
You get like little bits at a time.
Yeah, but there's it's nice because then like. You can say, how fast did we get it done? Under 10 minutes. That's great. And it's a great feeling. And very happy when you kind of get the open blood vessel.
I can imagine. Like I'm one of those. This is like probably TMI, but I'm one of those people that like the zit popping thing. Like
yeah, it's that kind of like satisfaction, right?
Like just yes.
And so it's funny you mentioned like, do they not come out? Because like sometimes like it can be very daunting because like you'll be there, you can be in there. Like the best case is like you're in, you're out, under 10 minutes, wide open, got a beautiful trophy to show the patient, patient's moving, everyone's high-fiving. Like that's the win. There's other ones where it's there, there's a challenging anatomy, you can barely get up, you're spending an hour trying to get this equipment to the spot, and then you're pulling and just the clot itself or the anatomy, and you can't get it out, and maybe you don't have a win, maybe you're not making the person better, and like it can be it can kind of like wreck your day. It's sad. Like I remember a story. One of our colleagues now, Dr. Watson, was just kind of getting up and trained and kind of getting his experience, and we had one that went really well, and then we had one like later that night that was just a bear of a case and challenging, and he's kind of, so we were grabbing coffee the next morning, kind of he's brutal case, it was really annoying, kind of sad, and then we got our coffees, and I went back and I was reading MRs that day, and then the name on the scanner was the same patient from last night, the win. And so I walk over to the scanner, and she's just sitting up. I'm like, hey, like, how are you? How's it going? And she's like, and I'm like, hey, can you do me a favor? Like, my colleague's really grumpy because he had a really bad one. Like, can you just like send him a little message over? So I have this video of her being like, hey, Dr. Watson, it's me. I'm doing great. And so like I sent him to that, and I was like, there you go. Stop being so grumpy. Like, this is like a really powerful thing. And then like a few months later, we're grabbing, coffee, radiology, coffee. Always a lot of coffee.
Good. Gotta stay awake.
Gotta stay going. So we're grabbing coffee, and then we're grabbing coffee at the parking lot, and the person who's giving us coffee is that patient.
No.
And she goes, "Hey, do you remember me?" And we're like going like, "Holy cow! Like, yeah, we do remember you. Like, how are you doing?" She's like, "Oh, I'm great." And so she volunteers at the parking lot now. So, it's like I know cold plunges are fantastic in the morning, but like if you need a good kickstart to your day, get a coffee from somebody who you saved from a stroke. Like so yeah, like I can be there and like, oh, this day's brutal, or like, oh, we're super behind, blah blah blah, and then like I'll see this patient and she gives me a coffee and I'm like, oh yeah, that's wild. Like
that is okay. So shameless plug, but all of the volunteers at the parking lot are KGH Foundation volunteers, and many of them choose to volunteer because they are so grateful for the care that they've received during a medical crisis like a stroke or what have you. So like in a way that makes me so happy as well, because it's sort of like this cycle of gratitude that's being perpetuated.
But it puts the biggest smile on my face when I see it in the
can
mornings,
only
it's just
imagine.
Like, it's so easy to get caught up in the day-to-day, and then like that kind of zooms you out and says like, okay, this is kind of what we're doing here and what we're accomplishing here with the foundation and stuff. So that's a really happy moment for me every time I get that coffee. I mean, the coffee's great too, but
of course, thanks, Cherry Hill. Shameless plug for them too, but I can only imagine, and there's a lot of complex problems that we're trying to address in healthcare right now, and I think sometimes we forget that there's just like really amazing, magical things that are happening in the hospital every single day. And I know sort of like sometimes the big picture can look a little bit daunting, but we have to remember that there's also the little picture of each patient and their experience. And I just love that it makes you so happy and excited. Just one patient is all it takes, hey?
Yeah, it can, it's amazing how much your emotions and your mental state can turn for good or bad on a single patient, right? But yeah, it's nice to focus on the wins when you can.
Totally, and I'm so happy that you shared that. So how did you end up at KGH? I mean, like your specialty is you could go and practice in any urban center. Why here?
Yeah, so I'm from Manitoba, and I was kind of hoping to be I love Manitoba, love my friends, love my community there. And so when I was doing my training, I did my fellowship. So you go and do extra training. So I ended up doing my post radiology IR specific training in Vancouver, which is a big center with a long history of IR. And so I was in Vancouver and was looking at various options, and the program director there, Steve Ho, who is tight with the radiologists here, said, you should check out Kelowna. It's a good spot. It's a good group. And what struck me about Kelowna was that the group here was really collegial. Everyone got along, but there was this sort of like a spirit. I don't know if you call it spirit or mentality. Whereas in other places I've worked, like things are siloed and things are kind of rigid, and these people did these procedures and those people did those procedures. Whereas here things were a little bit more like, okay, well, this patient's booked for a CT biopsy, but maybe we do ultrasound, so let's just move them there and we'll get this done. And there's kind of that can-do attitude of just making things happen and moving things forward. And certainly, when you're interfacing with healthcare, it can be really hard to bring new programs or do new things or do things that haven't been done before. Whereas here, there was just a lot of enthusiasm and a really good group of people and a lot of support for, bringing in new things and new ideas. And so when I started, I locumed here and really enjoyed it and just didn't feel the need to leave. And there's, there's things you know and things you don't know. So, the reason, I was like, okay, Kelowna's a cool place and the group's really good, but there's all these other things that like I didn't know about when I, took the job. Like, for instance, the HPB surgery team, which was a lot of the early IR stuff we did with the liver cancers and things like that. Like, Dr. Gareth Eason had just started here, who has done wonders for, accelerating the HPB program. And Dr. Solano is also. So these guys were super supportive early on and helping, send me patients and things like that, and sort of believing in this goofy IR stuff that may or may not have been convinced worked, and things like
experimental technologies,
totally, and things like the foundation, which is like I'll tell everyone, it's like a secret weapon here. It gets us all this access to capital equipment and other things that you might. If you're trying to just fundraise that alone, you might be by yourself. And, we had a neurosurgeon, Dr. Mike So, come here, who's kind of really taken us in new exciting directions with stroke and other endovascular therapy. So like all these other good luck has sort of shown up here, and I don't know, just good people keep showing up here, and it's really fun to work with them. And there's been lots of support. And so, yeah, I feel grateful to be here.
I agree. I mean, maybe we just have the good fortune of working with a great group of physicians and clinicians here. But yeah, that's definitely been our experience too, particularly with this new campaign, which is very anchored in innovation and thinking differently. And, again, like I said, there's all these stories about how, negative stories about healthcare, but like on the inside, there's a lot of really bright and like enthusiastic, hardworking, patient-centered people that are like in the system. And I think we just have to remember that. Dr. Farnquist said she chose to get into radiology because everybody looked happy.
I think a lot of people will kind of share that. Yeah, there's these stories, right? And like, we're also, when you're trying to choose specialties, it's this weird ignorance of like, you have these emotional reactions and things like that. But like, yeah, like, I remember being in some internal medicine wards, and it's kind of like, it can be plodding and drudgering and slow moving and whatever. And then you go to the radiology, and then people will be like, they'd have their coffee, as we've joked about already. But yeah, like radiologists, I think are pretty happy. And I think it's because we have there's a good ability to kind of work and have satisfaction from your job. And, every job has stuff that sucks, right? That stuff you get bogged down in and have to deal with. But there's just a certain, within medicine, I feel like, radiology is just like a nice sweet spot of, you can have intellectual satisfaction. You can kind of step away. I mean, it's getting busier though, right? Like, I mean, you've spoken to the integral role radiology plays. Like, everybody gets a scan now, right? Like, it's just, so it's becoming busier. But it's a great specialty. I tell everyone, like, try radiology.
If I could have a do-over, I would definitely go in that direction. Although I feel like that every time somebody sits in that chair, because I'm like, oh, that's interesting.
There's just so many, there's so many little cool niches and things like that for sure. But like, obviously I feel grateful. Like I'll put it out there. I think interventional radiology is like the best job in medicine. I'm on the care board, and so I get involved in trainees, and we have like these trainee days, and I just tell them like, you guys pick the best specialty, and they're so enthusiastic, and it's an intoxicating environment.
Did they get excited about clot sucking like you do?
Oh yeah, totally.
Get those goobers.
Oh yeah. No, you go on Twitter, there's just clots everywhere on Twitter. If you want to take a deep dive into the IR Twitter space, like
I don't know if I do.
You probably don't. I wouldn't recommend that for your listeners unless, I don't know if it has that flag of like warning, like graphic content.
I don't know if I finished that thought earlier about your enthusiasm for the blood clots translated into texts.
Yeah,
hey,
I remember I said, there was one, like, I think you just on a tour, and then there was a stroke, and then like the clock came out, and I was like, hey, look at this. I was like, and I think it was like 11 o'clock at night. And I was like, maybe like, can I undo that send? I don't know.
It was totally funny. I was just like, that's awesome. Like, wow, we're really in this together.
Oh yeah. You're welcome.
Yeah. Thank you for that. Thank you. So when you're not doing the interventional radiology stuff, like I know you don't do that every single day, or do you?
It feels like I do it.
Do you?
Well,
okay.
Sorry, I'm not like operating every single day, but like, I kind of probably referencing, I really love what I do. And so we have a really collegial group, and, we're always sort of showing cases or touching base, or, there's a everyone's got their group chats, but some patient comes in and says, hey, this patient's got this, and they might need a procedure in the next couple of days. So it's kind of always floating around. I think it drives my wife kind of crazy that I'm always kind of like getting involved and like, and it's probably, I'm sure my colleagues get annoyed that I kind of poke my nose in sometimes when I don't need to, but there's always something IR related kind of happening, even if I'm not at the hospital. Yeah.
Well, the reason I asked is because like I, as you know, have had my own opportunity to experience healthcare firsthand. And so I have to go for like a mammogram every year at the clinic. And a couple years ago, you were the radiologist there. And I was so happy it was you, because it's nice when you know who the radiologist is. And so I always ask, I was like, oh, who's on today? And she said, oh, it's Dr. De Korompay. I was like, oh, can I say hi? And you were there and you showed me my scans.
Yeah, it's kind of too bad people can't see their scans,
know,
right?
It was so awesome.
Because certainly, like, it's nice when we have our consults with our patients before we do surgeries, and we can actually, like, did you want to see your picture? And like, with Zoom and stuff, it's less, with COVID, it was kind of less, but it'd be nice, like, you'd be working someone up for a fibroid embolization or a prostate embolization. Yeah. Like, do you want to see what your fibroid? And they go, oh my God, that's huge. Yes. And, it's one thing if you go up in your med portal and read it, but, seeing is kind of everything. So I'm glad you could kind of see that and see what it looked like.
Well, it gives you so much, I'll just say, like, from my experience, like, you get the all clear, and it's great and it feels good, but to be able to see it, it's just like such a relief, I was like, oh, this is,
Yeah, there's something where you can be like, yeah, here's the thing, and then it's no longer there. And like, I think, that people, you don't have to be a doctor to kind of interpret that, right? Like if there's a big mass that you
and that's kind of what you showed me. It's like, this is it, and here we are today. And, again, it's just another entry point to just remind people to, be proactive with screening if it's available, like, because this technology is so amazing that you can catch some of these things early, right? And that's like, well, okay, some people would say a mammogram's kind of invasive, but compared to,
other things,
for sure. Like, I would say, like, no, not invasive. And there you are. There you have the information that you need, just a scan, right? So it's awesome. I have a lot of love for the radiology field in general, and then just learning more about interventional radiology and just like the magical things that it can make possible is pretty awesome. So I referenced the fact that you're kind of like a people person. And I think that's, I wonder how your wife handles you. You're like obviously very academic, and I didn't know the part about, sort of being like so driven and perfection oriented. Maybe you didn't say that. Maybe I'm just making.
No, I think you read between the lines correctly on that one.
Yeah. But like one of the things that really stands out about you is that you have this amazing connection with our donors. Why? And you don't have to do that. I mean, like, literally I can call you and be like, hey, let's, do a story, a little interview, blah, blah, blah. And that can be done. But you're like, I'll meet with the donors. I'll take them on tours. Like, why? What about that is just so compelling for you?
Yeah. I mean, you referenced, my wife, and she tolerates me. She's such a saint that she puts up with me and allows me to do these things. And I really do appreciate, like, none of this would be possible without her.
Good. Send some love. There we go. Yeah.
But no, I mean, I think, the point you made before about when you were out there and getting your scan and like, referencing just having the relationship and being able to come and kind of like seeing is believing, right? And so hearing about things in abstract is one thing. Mm-hmm. But, I think I have that interaction myself with the patients. I had experiences where I show patients their scans or I get the chance to do that. And it's the same thing with the donors. And it's just kind of spreading the gospel of sort of, the things that are possible. And I think it's so easy to get lost in the negative stories and negative things like that. And I just think, if you only just read the news, potentially you could just have this horrible outlook on healthcare and life. And it could be if you're in the UK, it could be if you're in the States, it could be if you're in Canada, right? I think those negative storylines sometimes just play well, and that's why you hear a lot about them. But when it comes to donors and like, make no mistake, like the ability that I have to do stuff with the equipment we have and the facilities that we have, like, I'm so grateful. Like, I'm so eternally grateful, because one of the worst feelings you can have in medicine is seeing a patient and thinking, I could have done something for this patient, but I can't, or I can't because of X, or I can't because of Y. And, if we were sitting here right now in this day and age and there were stroke patients coming through and we're saying, well, if we had this, we could help them, but not, we're just going to watch them, potentially, be debilitated or die.
Suffer,
like
yeah.
That is a horrible feeling as a healthcare practitioner to say, if this patient just lived in a different place, they would have better access to healthcare and they would do better, but because you happen to be in the wrong place at the wrong time, like, you're screwed, right? Terrible feeling. So for me to be able to do my stuff, to offer, to be able to offer all these therapies, and, sometimes they're not curative or sometimes they're not successful, but just to give people the chance, I am so grateful. So I'm so grateful to the donors. I'm so grateful to the infrastructure here that's enabled that. So I will dance like a monkey for you guys if you need me to, because, and it's not even performative. It's just like, if I can communicate the stories to the donors, to people who are interested in donating, saying, hey, this is what you can do. This is what you can accomplish. This is the output that you're giving results in. I think it just resonates. And I think, when I remember we were doing the Zoom ones during the EVT, because of the thing, but that was kind of good in a way, because I had my computer with my little presentation and I could be like, yeah, here's an angiogram. And, maybe you don't know what a angiogram is, but like, blocked blood vessel, open blood vessel,
right.
Happy patient. And yeah, you could see that kind of really translating. And so, yeah, for me, it's just, I have this enthusiasm. I'm grateful. I love what I do. And I just want to share that with people. And hopefully, the same way I'm inspired by the ability of our teams and stuff to do good work, I hope that inspiration can kind of translate to them and, influence them to see if they can contribute and be part of our kind of team.
Yeah. And I really do thank you for allowing that to be the truth, I think, for our donor community, the KGH Foundation donor community, and even the community in general. You have really provided that opportunity to get behind the curtain and really see the impact or potential impact that this has, not just on patients, but on like physicians, like the people that are actually providing care, how important and truly transformational that is. So, yeah, really grateful for you. Totally. So we talked a little bit about this before we started recording, but you are a newish dad. Yeah. So fun. How do you I mean, I have children. They take a lot. How do you sort of balance work and family life?
I mean, not well, I don't think. I mean,
maybe we should get Kyla on here.
Kyla would probably have a lot to say. No, it's challenging. So obviously, I really like what I do. I really like my job. I really like the work. I think, Kyla and I had conversations, after we were married about family planning and things like that. And I feel fortunate because I didn't want to be in a position where I felt like I was choosing one or the other.
Yeah.
And I don't feel like I am, which is great. But I certainly know of colleagues, that have children during training, during residency, during fellowship. Like when I was a resident and a fellow, I had the luxury of being able to be sort of, like a monastic one-track focus on sort of learning my craft and, going all in. And not everybody has that option. And I feel grateful that, Kyla supported me in that and I didn't have to choose between work and family. And now I'm at the point where, I've got this great team of people, so I don't have to sort of be involved 24/7, even though I kind of insert myself sometimes.
Of course.
But yeah, so in some ways it's good because I think having my son Lennox, it's helped me kind of pull back and appreciate that there's, it's not just about medicine. I do love my job, but it's not like they're going to be building a statue in front of the hospital for me when I die, kind of thing. Like it's we're all replaceable at the end of the day. So as much as I love my job, there are other important things in life. So that's helped me pull back. But it is challenging because, I think, looking back to my dad and sort of that generation, right? It was sort of, it was very much, a lot went on the partner in the marriage to kind of deal with everything. And certainly it can be hard for Kyle. Like I sometimes I don't know how she puts up with me, because, we'll be having dinner, like, oh, there's a stroke. And like, are you on call? No, but like, this was a tricky one. And like, and we try to do close grab. So I was like, I'm going to go help and blah, 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 blah. Do you need to? And so it's this kind of like, it's tough if you're, I don't know in terms of when your family was younger, but if your partner just had to sort of drop everything on a moment's notice, whenever, just to go, and it's a tough argument with your spouse, right? Because like, well, like, do you need to go? It's like, well, somebody's life is at stake. Like, of course I have to go. Like, and you can always change the narrative.
I'm going to actually play this for my husband, who's a realtor.
Yes.
Who also has the same commitment to dropping everything when he gets the call. But to your point, nobody's life is at stake.
Right. But certainly, so you feel the pull, right?
Yeah.
And so that's been a challenge. And I think I've always really enjoyed having pursuits outside of medicine. Like, when I was in med school, I was playing, Your Son's a Varsity Blue, and I was playing for the U of T at that time. And so I always really enjoyed that I had other things. But
did you play football?
Soccer.
Yeah. Okay.
But certainly, like, it very much feels like, it's kind of working kid right now. And like, he's young, so I know that won't be like that forever. But it's a challenge. Like, it is a challenge. Like, how do you, I don't have a good answer for this. Like, I don't know in the modern era, like, because like, I want to be the good doctor, but I also want to be the good dad.
Yeah.
And my dad was always there for my sports games and soccer games, but like, there's days you didn't see them, kind of thing. And like, so I want to be the good dad. I want to be the good doctor. I want to have my own life, but like, there's just not enough hours in the day. And so I haven't figured that out. I don't know what the right answer is. Like, what's the saying? You can do anything you want, but not everything.
Yeah.
And so like, I've always tried to do everything, and like, I'm really running into that, like, trade-offs. It's all trade-offs.
Yeah. It's a fine balance for sure. Yeah. I don't think any of us really figure it out. We just do the best we can. Yeah. Well, if Lennox ends up being, would he be a third generation physician?
Yeah, so my dad was the first in the family, and then so he would be third. Although actually we were having our neurovascular rounds this morning. We were getting ready to go, and I had them on my phone while I was kind of watching him, and he's kind of looking at the brain aneurysms and stuff like that.
Was he?
Oh yeah. It's funny.
It's starting.
Yeah. I don't want to like. No. I don't want to force him. Maybe he'll be like that. Like,
maybe he'll want to be a realtor.
Maybe.
Marketing director. Yeah. Lots of options.
Whatever. Honestly, like whatever makes people whatever gives people passion, and whatever they can find passion. And that's for me. I've drumming this beat again, but like, I'm just so grateful I found something I'm passionate about. Yeah. And for me, that's kind of what keeps me going. It
makes a difference.
It totally makes a difference. Like, on bad days, good. Like, they talk about when I was picking medical specialties, I remember somebody saying to me, like, you're going to be spending a lot of hours a week doing this. Mm-hmm. So you might as well find something that kind of gets you going, because otherwise it's a lot of time to be spending doing something you're not into.
Oh, 100%. I'm going to just sort of switch gears. I feel like I already know the answer to this, and, we're just wrapping up here. But, this is the Wealthy Podcast, and we know that health is far more than just sort of physical, freedom from disease or injury, what have you. So, what areas of your life do you feel wealthy or abundant?
So I feel like I'm, pretty blessed in that I garner a lot of sort of stimulation and satisfaction from my work. Mm-hmm. I think hopefully that kind of shines through. And in my relationships, both my, and I'm lucky. I mean, a lot of my friends are my work colleagues, right? Like, and I kind of get the same sense with you at the foundation. I feel like you guys are all kind of total bros, and you have a good time. But like, I love work. I love showing up. I love chatting cases. I like helping out my colleagues. So I feel like from, a stimulation point of view, from a satisfaction point of view, from a relationship point of view, I feel like I've got a lot of, wealthy, healthy kind of life there. From my, relationships with my wife, with my son, with my family. I feel I've got a great group of friends as well. So I feel like really, I'm really, really fortunate to have that. I feel like at this point in my life, I'm 40 now. I used to be a lot more active. I feel like my physical health could probably get a little more attention, and kind of to our earlier point about finding time.
There's only so much time.
There's only so much time. Yeah. And like, I used to get a lot of satisfaction for just like playing soccer, being physically fit, being physically active, and that's definitely taken a back seat. Life is trade-offs. So I hope to kind of, once the young child family life thing settles down, get back into that a bit more.
Yeah.
But yeah, I mean, in terms of sort of, my spirit and my intellectual curiosity, I feel like, again, I keep saying again, I'm very fortunate that I've just found something that kind of ticks all those boxes.
Yeah. It makes such a huge difference. Like we've said, you've mentioned gratitude a couple times. I'm going to kind of close off here. Is that something that you have intentionally cultivated around, like, I mean, we hear about have a gratitude practice, wake up every day. And like, I'm not trying to minimize it. I think it's a really valuable practice. Name 5 things that you're grateful for before you go to sleep at night or whatever. Is this something that you have worked on, or do you feel like you've just come to that place?
Like many things in my life, like I've just had a lot of really good dumb luck. And I'll contextualize that. So, the best and the worst part of my job is dealing with people in their worst moments. Mm-hmm. Right? Like, I remember a surgeon telling me once, like, about giving bad news is, there's only so many days people remember, right? Like, you remember like your prom or your wedding or the birth of your child, but like people will remember the day they got cancer or the day they had their surgery, right? Mm-hmm. And so, usually, or often I'm involved in those kind of moments with people. So it's not like I've, come to this gratitude mentality from journaling or from, mantras or whatever, but just the day in, day out of dealing with people on their worst day it really provides context, right? It's kind of like the lady at the parking lot who gives me my coffee, right? Mm-hmm. It's just that context. So, I'll be having a bad day, or I'll be hung up on some stupid nothing little thing in my life, or, maybe I dinged my car or whatever. And it's easy to kind of get hung up on that. And then like, you're like, okay, let's go see our next patient. This is a patient with, metastatic cancer, or a patient with cancer, or, right. You're putting a port in for somebody who's getting chemotherapy. Like, and so it's just, I'm constantly running up against people who are just going through just hell, right? And so that has kind of cultivated my outlook, because I feel like it's really easy to lose sight of the important things. But then, to your point about health and wealth and that being important, like, yeah, I see how fortunate I am that I have my health and I have my family and I have my friends and loved ones. And because there are people that are going through hell and don't have that. Mm-hmm. And so that I am meeting with those people every day. And I think that is what has resulted in that worldview for me, is just seeing people that are just dealing with the things that life can throw at you.
Mm-hmm. Thank you for that. I always really enjoy talking to you, but it's just been nice to sit down for an extended period of time and get to know you a little better. You're a very inspiring human. I love your energy, and I love that you've sort of finished there, that the fact that, every day you see people that are weathering kind of like the hardest moments of their life, and what grounds you is realizing sort of like how delicate and blessed we are to have our health. And so we can cultivate gratitude for that. There's always something to be grateful for, even in the hard days, right?
Totally.
So thank you, Nevin. This was super fun. I hope you enjoyed it. You said this was like your first formal podcast.
Yeah,
so
thanks for introducing me to the format.
Yes, I feel like you're a natural.
Well, not as good as you. You're killing it. This is fantastic.
I've said it before and I'll say it again. I've always dreamed of being Oprah. So here we are. Probably not there yet. But anyway, it's a pleasure. Thank you so much. And continue doing the good work you do.
And same to you.